Over to you, Ganesh and Saurabh.
Thank you, everybody. Thank you, Chairperson. I mean, this is not a topic.
This is a very nice recent concept of Dr. Bakshi, tandem talks, very nice.
Bladder preservation, T2.
16, yeah.
16. Initial. So, we both are discussing the topic bladder preservation versus radical cystectomy in T2 MIBC. I am at PD Hinduja Hospital, Mumbai. Saurabh Patil is at Fortis Hospital, Mumbai. And this is not a debate. We are having a debate on this topic for a real long time, maybe last 4 or 5 years. We have heard debates in many programs. So most guidelines, including EAU, give a grade A recommendation for treating MIBC T2, T4A, N0, M0, and also high-risk NMIBC with radical cystectomy. It does accomplish a paramount target in bladder cancer treatment and achieves very good oncologic control with acceptable morbidity. Around the world, it is the standard of treatment for patients with MIBC. The relapse-free survival rates are quite good at 5 and 10 years, as seen 62 to 68 and 50 to 66%. And a big series by Hotman with radical cystectomy showed a 10-year cancer-specific survival rates of 67%. But patients do come with this question to all of us. Is there some other treatment, or can I save the bladder in spite of radical cystectomy being the gold standard, so-called? We are not talking about the diversion at all right now. Patients would be like refusing to get out with the bladder, and some cohort is unfit with respect to surgery, anesthesia, or both. Looking at the evolution of bladder preservation, so it was tried in many possible ways. Only TURBT, maximal, only plus RT, TURBT plus chemo, and the more successful is the tri-modality, which has maximal TURBT and chemo radiation. Another success, slightly, which has been published is the tri-modality plus partial cystectomy, and this actually came through with the thought that TMT patients, it was seen that in TMT patients, 10% had residual tumor, 2% had lymph node metastasis, it might be 2 to 5% in actuality. And yet, this technique was very good. This suggested that consolidation surgery might have a role along with that. So, I would like to ask Dr. Saurabh, we have two options. So, how would you what is your take on the oncological efficacy?
Okay, so this is the most important question and at the same time most difficult question to answer, because unfortunately we don't have level 1 evidence for this. We have what the RCT which was tried had to stop because of limited difficulty in accrual, so we don't have level 1 evidence, but we do have some good literature. This is a recently published systemic meta-analysis where authors included good number of articles with propensity scoring matching, and what they found was a short-term survival outcomes were comparable in both the groups, but after 5 to 10 years, RC overscores and has higher overall survival rates compared to TMT group. Same happens with cancer survival rate. So initially for 1 or 2 years, TMT is better, but for long-term results, RC scores better. So authors concluded that RC, radical cystectomy, should be chosen over TMT unless patient is not fit for the surgery or patient is strongly desired for the sparing of the bladder. This is another meta-analysis with the same results, that initial phase for maybe short-term or mid-term, 5 years, results are better or comparable with TMT and radical cystectomy. But as we move forward after 10 years, radical cystectomy definitely scores over TMT. Like Sir said, tetramodal therapy, when we include partial cystectomy and pelvic lymph node dissection to overcome the limitations of residual tumor mass at the site of TURBT and lymph node, lack of regional lymph node dissection. A Japanese group did one study, prospective study of around 100 patients, and they found very impressive results in form of more than 90% of cancer-specific and overall survival. But this is only one study. We should have some more data to validate these results. Multi-institutional matched comparisons published in JCO. Same authors published with the same group, slightly better, more number of patients. And this is the paper which is quoted in the most of the journal, and this is the maximum level of evidence that we have. in which this is a retrospective analysis and the variables were balanced after propensity score matching. And authors, these patients were treated at 3 high-volume centers where radical cystectomy were routinely performed, and they did a good cancer, very well-selected patients. Solitary tumors less than 7 centimeter, no hydronephrosis, and no extensive multifocal tumors. These candidates were eligible for both radical cystectomy as well as TMT. And what did they found? They found no difference in any survival outcome. In fact, overall survival was better in trimodal therapy. Salvage cystectomy in 13% for recurrences. Inside bladder recurrence was 31%, outside bladder was 8% compared to RC. It is only 3% because we are taking out the bladder. Mortality perioperative was 0 in TMT, 2.5% in cystectomy group. As far as recurrences is concerned, muscle invasive were seen in early phases and non-muscle invasive were still present even after 5 years. This states the importance of long-term surveillance. So authors concluded that since we don't have any RCTs, we should offer this trimodality therapy to all eligible patients. That's the most important thing. So to summarize the outcomes, we don't have level 1 evidence, but we do have good evidence with propensity score matched studies. Many of these studies have data to prove that TMT is comparable to radical cystectomy. However, they have some inherent biases and flawed results. Most important question is which patient. So, sir, in practice, to whom we should advise? For all young patients, for all those who are interested in saving the bladder?
So there are selection criteria. This is a MGH study with 2 phases between the study. And a later phase, they selected quite stringent criteria. All were, most were PT2, CT2, 100% were without hydronephrosis. And then in the later part, actually in this cohort, they achieved very good results. This study demonstrated that in well-selected patients or more selected patients, it absolutely offers very good outcomes. So they strongly recommended good selection. When there was no proper selection, the 5-year CSS was 38%. It's quite low. With properly selected, the 3-year CSS was 71%. But just to highlight the last line, if one uses similar criteria as for the best TMT with surgery, the surgical results go beyond excellence. The historical series of radiation alone have suggested that the selections of flat lesions, incomplete resection, locally advanced stages, and presence of ureteral obstruction did very poor response to RT. And tumor-related hydroureteronephrosis was excluded in most RTOG studies. About 10 to 35% of eligible patients where HUN was present were all poor outcomes, and the response rates without HUN was 1.5 times better. So if you see, these are more series. If I say Hussain et al., the first one, the fit patients for surgery, but those who took TMT did very well. And the patients, again, who had maximal TUR as opposed to residual or just biopsies did not so well. So if we have a 7 centimeter post-TURBT residual mass today, probably I would push this patient for radical cystectomy, but as Saurabh just said, you saw the bladder preservation data. This patient can go for bladder preservation. So, how would you counsel, Saurabh? We have these 2 options again with respect to the side effect profile and quality of life, which are one of the main points in oncology patients.
Correct. So this is also the second most important question to answer. Radical cystectomy, we all know, is not devoid of any complication. I will not go into the details. As far as TMT, trimodality therapy, is concerned, in initial studies, we found higher grade 3 and grade 4 toxicities in the tune of 21% GU and almost 10% GI toxicities. But as we grow in experience or maybe with better radiation technologies, these grade 3 or late grade 4 side effects have come down to hardly 5 or 1%, and less cystectomy rates are 7 to 15%. This is a review on patient-reported outcomes of quality of life, but unfortunately only 2 prospective studies are there. It states that bladder preservation therapy offers a better general quality of life in terms of satisfactory urinary and sexual function, but at the same time worse GI symptoms. There is another systematic review published in European Urology which stated slightly higher and worse picture as far as complications are concerned. Grade 3, grade 4 toxicities in 10 to maximum 36%, recurrence in maximum 43%, salvage cystectomy required in 25 to 30%, in all series it is less than 20%. And the problem with salvage cystectomy was our options of divergence were limited, and the chances of orthotopic neobladder were minimal. But again, all these studies, like we discussed, was small cohort, had some flawed and inherent biases.
So this was one of the studies we had done at Tata Memorial with prospective cross-sectional 104 patients, RC versus bladder preservation. And if you see the EORTC, QLQC, it's almost the same. If you see the bladder cancer index, as we just said, the sexual domain bladder preservation makes a better difference where the RC does not score. And on basis of that, this compact study was planned and it is in process actually. So overall, with our Tata study, it was overall bladder cancer survivors have good QOLs. There are no differences in urinary bowel domains with radiotherapy surgery. Sexual bother scores are better with bladder preservation. Quality of life should be the central thing. Again, we should remember that there are selections with bladder preservation.
This is the first systematic review we have published in 2024 in Green Journal, assessing the quality of life after different surgical approaches like radical cystectomy with ileal conduit, radical cystectomy with neobladders, and TMT. Out of that, neobladder has some advantage over ileal conduit in form of physical and emotional functioning. But out of them, TMT has a trend in favor of in all functional aspects. As far as cost is concerned, initially, again, for 30 days, the cost is same for both these modalities. But after 30 days, or as we move for 90 days or 180 days, cost is definitely higher in trimodality therapy, maybe because of surveillance cystoscopies and recurrent follow-up. The problem with salvage cystectomy, the side effect, initially, again, so this particular journal, they looked into the three factors: salvage cystectomy, primary cystectomy, and primary cystectomy after irradiated bladder for another malignancies. So they found no difference in all these three cohorts as far as early complications are concerned, but salvage cystectomy was associated with late complications like small bowel obstruction, ureteral stricture, and parastomal hernia. Again, like I said, it reduces our option of diversion to only ileal conduit. These chances of orthotopic neobladder is reduced.
How do you manage follow-up protocols in both these modalities? Because if you generally ask your friends who are radiation oncologists, they are not so clear. But nowadays with discussions among various forums, this clarity has started coming up. Radical cystectomy, we all know this is our standard follow-up protocols. If you see bladder preservation, there are too many things to be done. And as Saurabh just said, the costs increase quite a bit. We have reached the conclusion here. So while one can argue to support both therapies with selections, bias, whatever, a comparison between radical cystectomy and TMT is difficult because there is no straightforward good evidence. Direct comparison has been confounded by always selection bias. Cumulative data have shown acceptable outcomes and may be considered a reliable option in well-selected patients. However, based on large body of evidence, radical cystectomy remains the optimal choice still for many patients. Thank you. So, any comments from our chairperson?
Thank you. I think both of you have done a good job. I will only like to say this is a shared decision. We as a surgeon or the oncologist should not take the blame on us. We have to discuss with the patient and he should be told very clearly what you have talked right now. And if he agrees, and then we should go ahead with that accepted line of the treatment. Thank you very much. My co-chairperson, if you have to say something.
Can I ask a question? Yeah, Dr. Ganesh, you were a part of that study, right? And that's the reason why I wanted you to take this topic. So in your actual experience, let's not talk about the published evidence, but in an actual experience, how were the patient's bladder behaving after radiotherapy? I mean, all of us in the hall have a clear apprehension that after radiotherapy, bladders are not going to behave well. Patient is going to have GU or GI toxicity, and which is persistent as the time goes on, it increases further. So I just wanted you to share that experience.
So what happens normally is after giving radiation, I mean, the question was very specific. So radiation oncologists always talk about acute and chronic. So the acute phase, usually they never let the patient meet the urologist, very honestly. So I have seen a few patients even then and done some scopies, and we would really see angry bladder inside. And there are some people who have a terrible bleeding also. So that is for the acute stage. About the acute GI complications, they are usually warded off as going on, or if side effects which are normal with radiation. So nobody actually looks into them as of currently. Going to the chronic ones, it is clear that we do see there are few well-selected patients. Otherwise, in many patients, we see the superficial recurrences, which we do a standard TURBT. Now, the literature does say that even after that standard TURBT, you can offer BCG also, but that is altogether different, not going into that topic. With MIBCs, we had always proceeded with salvage cystectomies, which has its own rate of complications, as Saurabh mentioned. So, long-term, a patient is willing, I would still offer a cystectomy. But there are patients, as Sir said, shared decision-making, complications, both sides, everything, and we could offer them. But at the same time, I tell patients today that if you are going on bladder preservations, do not forget to remain in touch. Thank you.
See, Dr. Ganesh, everyone would like to preserve bladder because it definitely affects the quality of life. So is there any role of novel biomolecular markers or any genomics in current era for selection of patient when we can select bladder preservation protocol safely?
So we have not got absolute markers for doing this selection, but usually P53, MIB1 index, these are the common ones in bladder which tell us that the disease is very aggressive, apart from any special histopathologic characteristics. Otherwise, we have not got. I mean, the variants which would be there in the bladder. So variant is one topic we have not touched here consciously, but those would be slightly aggressive, apart from MIB1 and P53. So nothing like that.
Fantastic. And what is the current status of virtual cystoscopy for follow-up of this patient?
I have not been doing, so I think a proper cystoscopy is much better, because many times, you know, virtual is based on imaging and software. So many times today we would have a CT or MRI which shows something, and sometimes you would find something.
Yes, I support you, and I rather emphasize this point. Nothing can substitute having a look inside the bladder, that is cystoscopy. We have seen patient, even CT has missed the lesion. We have seen patient, even the CT has missed the lesion, and when you do cystoscopy, there is a well-defined tumor is there in the bladder, which we resected and came out the same as the cancer. But as you mentioned earlier, we should not substitute cystoscopy with any other diagnostic modality. And considering the follow-up, the same applies to that. Thank you very much.
Unless we have a strong evidence with that, I think we should not proceed, because patients will hold you liable for something. Thank you.
Sir, we were speaking about whatever evidence is there for that we want to offer TMT to selected patients. Sir, I have a problem with the evidence, because if you look at it, almost all of them are retrospective, maybe going up to 10 years. So it would appear very strange that in countries like North America and UK, at a time when TMT was not even considered, a significant number of performance status 0, very good risk patients were actually counseled to undergo TMT. So that itself points at a very big aspect of selection bias in these studies, because it is strange that 10 years ago somebody would say that you go have radiotherapy for your muscle invasive CA bladder. Then if you look at this study which Zlota et al. Have published in Lancet, you'll see that out of 1,500 cystectomies that they have done, only around 28% were found matching to the TMT group. So if you're doing a propensity score matching, you can have a 1:2, 1:3, 1:4. How is it that out of 1,500 patients, only 300 were matched to the TMT group? So that means that you preferentially selected out the best case scenario for radiotherapy and you matched them to the worst case scenario for radical cystectomy, which itself is a huge source of bias. And
Rahul, we are time up. You come to the point.
yes, so I think, sir, there is no evidence for me to even offer.
So basically, let us not discuss. We know about the bias,
Yes.
but propensity score matching is a method
Yes.
or a methodology. I think we should not blame the methodology. They try to be equal. That is what we would say. I think.
Yes, sir.
Thank you.
I think that let's leave this topic. Thank you very much.
Thank you, chairpersons, for your wonderful discussion. So we'll move on to the next session, and I'll invite Dr.